Now, this is a 70-year-old man with a violaceous nodule on the nose, and the patient has a history of rhinophyma, that enlargement of the nose, that kind of multinodularity that comes from extensive sebaceous hyperplasia, perifollicular inflammation, and eventually kind of rupturing of these cystic structures and scarring. Many of you are probably familiar with rhinophyma. But in this patient, he has something else aside from rhinophyma going on. And you can tell this is also a large excision. In real life, unfortunately, we don't often start with large excisions. We start with small biopsies and have to figure it out from there. But for teaching purposes, I think these large excisions can be quite demonstrative of the features. Right here, you can see, in addition to the fact that there's a biopsy site, you can see that there's a proliferation here of something. A lot of inflammatory cells, for one thing. As we go down closer and look, in the midst of the inflammatory cells, you see these very hyperchromatic atypical cells that are kind of epithelioid to and they've got lots of complex spaces filled with blood in between. So as probably most of you figured out, this is infiltrative vascular channel formation lined by atypical endothelial cells. These are the hallmark features of angiosarcoma, another lesion that usually occurs in the head and neck of elderly sun-damaged patients, although we can see it really at any site, particularly the breast, after in the setting of radiation exposure. I don't often see post-radiation angiosarcoma of the head and neck, even though the head and neck also gets radiation. I'm not sure exactly why that is, if it's just that it's just not common to develop. I do feel like the breasts have a particular predilection for developing angiosarcoma. That's just my personal kind of view. But in any case, most of the angiosarcomas I see of the head and neck are probably related to sun, I think. They seem to almost always be in older people that have had a lot of sun exposure. And the key features are the infiltrative growth and the atypia of the cells. And you can see very hyperchromatic and pleomorphic atypical cells here. The vascular channel formation, that can be a real challenging thing to evaluate in vascular lesions, to tell when is something infiltrative enough to be concerned. And there are some benign vascular proliferations that can mimic infiltrative growth. And that's a topic for, you could have a couple hours of lecture just on that topic alone. I'm not going to put you through that, but I do have some videos on my YouTube channel about vascular tumors of the skin you can check out if you need some teaching in that area. But I will say that one feature I find really helpful is this. See the little kind of slightly fibrillary pink stuff here? That is actually dermal collagen. And what's happening is each individual dermal collagen bundle is being completely wrapped and surrounded by atypical endothelial cells. The cells are digging down into the reticular dermis and they're wrapping around every individual bundle of collagen they can get their hands on and digging deeper and deeper down into the dermis. That is the classic characteristic way that angiosarcoma of the skin usually grows. Okay, you can sometimes see a similar growth pattern in Kaposi sarcoma. The main things to remember there is Kaposi sarcoma usually does not have such striking atypia and pleomorphism. And the other thing is that in Kaposi sarcoma, if it's on the head and neck of an old person and it looks like Kaposi's, I'm going to call that angiosarcoma until you prove to me with a positive HHV8 stain that it's actually Kaposi. Or if the patient has known AIDS or something like that. Otherwise, I don't care, even if it really looks spindled and looks like Kaposi. I've seen angiosarcomas that got spindled and had slit-like vascular spaces and closely mimic Kaposi sarcoma. And so I want it proven with an HHV8. Usually when older patients get Kaposi sarcoma, they tend to get them on their feet or their lower legs. And that's the kind of classic form related to immune dysfunction that kind of comes with old age. And again, we now have HHV8 immunohistochemistry, which can easily solve this problem. So if you have any doubt, do an HHV8, because the difference between angiosarcoma and Kaposi sarcoma, even though they both are called sarcoma, is a night and day difference in prognosis and treatment. Angiosarcoma is quite aggressive and unfortunately is still to this day has a relatively high mortality, although I have met some patients online through Facebook patient support groups that I volunteer in who are long-term survivors, which is wonderful, but it's still a very serious disease. It's often treated quite aggressively. Kaposi, on the other hand, tends to be indolent. Most patients don't die from it. There are some exceptions, like in cases where patients have uncontrolled AIDS. The other thing about it is that it's not really curable. Kaposi sarcoma is treated kind of palliatively for symptom control, but you don't cure it with surgery and chemotherapy. Sometimes you can get it under control when you get the person's immune system under control, like if you treat their HIV. So anyway, that's Kaposi, but in angiosarc, it's very different. So the point is, make sure to make that distinction. Here's an example at the very surface here. Oh, I should probably rotate that. I always like to play the game of what if we had a shave biopsy down to here? What would I be able to make the diagnosis, which is a scary game to play, but it's an important one. And I don't mean that to be too flippant. I mean, it really is serious for training ourselves in DermPath to think about if I had a small superficial biopsy, would there be clues that would help me realize something worse was going on down below? Clinical images and clinical history is crucial. And as you already all know, that's an important thing. And sometimes we're lucky and have clinical colleagues who provide that. And sometimes we do not get that information. But working with the clinical team to get clinical photographs can be priceless when dealing with skin lesions, especially one of these. If I get a small biopsy and all I see is some dilated, benign-looking telangiectatic vessels, that's probably just a benign telangiectasia right here. And there are some scattered atypical spindle cells, but you know what? I see that in sun-damaged skin often. I think they're reactive fibroblasts. In this field, nothing here would have triggered my concern for an angiosarcoma. But if they told me there was a 2-centimeter violaceous nodule that had been growing, then I'm going to be concerned that what I'm seeing here may not be representative and may not be telling me, giving me enough features to support what they're seeing clinically. So that's where it's really crucial to get that clinical info. So the other thing I wanted to point out about this case is look at how much inflammation there is. Angiosarcomas often have a lot of background inflammation, as this case perfectly demonstrates. And when you have a subtle one, sometimes the couple little atypical vascular channels can hide in the background inflammation and be hard to see. This is a very florid case that I'm showing you. Not every case is so straightforward. Sometimes the atypia is more subtle. Sometimes the vascular channel growth is very subtle and trickly. Those can all be problematic things. So here, I don't even know that you need any immunostains. I think this is very characteristic on H&E, but if you want, you can use vascular stains to highlight the infiltrative channel growth. Also, sometimes you can have solid areas that are very cellular and spindled in angiosarcoma that can resemble atypical fibroxanthoma or pleomorphic dermal sarcomas. So on those, having immunostains can help prove that something's vascular. My favorite immunostain for vascular tumors is ERG, E-R-G. It is a very, very sensitive and very clean, crisp marker, but it is not totally specific. Other things that are not vascular can stain with it. CD31 works very nicely, but I will highlight that it does stain histiocytes. It tends to have a weaker granular staining in histiocytes. So using the normal background blood vessels in the skin as control is really helpful when evaluating vascular stains. I want an angiosarc to be strong, diffuse positive, the same level of intensity as the background normal endothelia has. Okay, and CD34 often stains angiosarcomas, but I've seen a handful of cases that were totally negative, that lost CD34 expression. So while it's fine if it's positive, it can be negative, and also it stains a whole bunch of other things. So it's not my favorite, but it can work sometimes. If I'm having a difficult case, I'll sometimes do all three of those markers. D240 or potoplanin, which is a lymphatic immunostain. It tends to stain most angiosarcomas. For some reason, angiosarcomas, even though they have obvious blood-filled spaces, they have a lymphatic phenotype most of the time, and usually will stain with D240. So I don't routinely use that in my practice, but in a hard case, it could potentially be helpful. And again, just a closer look. If you haven't had a chance to view this digital slide, I encourage you to do so if you want a very characteristic example of angiosarcoma. And unfortunately, this took several surgeries to clear this tumor, and a very unfortunate site to have an angiosarcoma on the nose or on the face.